So roundtable can sometimes be a little bit chaotic, so I try to do it a little bit systematically. I prepared myself with questions. I have to say many questions have been already discussed. Repetition is always good. I'm going to give you the microphone and you can just hand it over to whoever is asked. And of course, if anyone has an urge to say something, feel free to just speak up your mind. So I think I don't need to introduce everyone. We have here a group of adults. Professor Mariani and Chris are mostly in adults, and the rest are pediatric, although Dr. Pica does both, I guess. And first of all, I would like also to do it a little bit interactive and see what you guys learned, or what are your opinions. So if you could scan the code, there will be some questions. It's anonymous. You don't need to raise hands. We won't see who is thinking what, and I think that will be interesting to see what you guys think about the case I'm going to present. You've seen this case already. We don't have a lot of craniopharyngioma cases. That's why they repeat themselves. But the case is not important. It's more the discussion of the case and the points we want to make on the controversies that we have in craniopharyngiomas. Does it work?
Yes.
Good. I'm happy. So first of all, let's see, who are we dealing with? Please let me know who you are, or let us all know who you are. The panel can also... I want to know your opinion, guys. Wow, we have a lot of neurosurgeons. Okay. Okay, interesting. I didn't expect as much neurosurgeons, but it's good. So we have some general pediatricians, endocrinologists. Okay. So now that we know who we're dealing with, let's see what you think. You can just type in what pops in your mind. One word. What is the most controversial topic for you in craniopharyngiomas? You heard a lot of things. You probably have now an idea. What would you say is the most controversial topic? Surgery, radiation, obesity. Okay, it's starting to show. So whatever is big, more people typed that in. And since there are a lot of neurosurgeons, yeah, surgery is always the focus of everything. We know that.
It's a statistically significant because there are mostly of the people are surgeons.
That's true. That's true. We are biased. But still, you see, quality of life, obesity, extent of resection is kind of surgery. I'm sorry, radiotherapy is a little bit small. Yeah, okay, so you see it's a lot of topics, okay? There are a lot of controversies in craniopharyngioma. Of course, surgery is one of them, and also quality of life, which I do agree with. And this is the case you already saw. Just for sake of discussion, again, this is an 11-year-old boy. He had a growth retardation with low growth hormones, no visual deficit, pituitary axis is intact otherwise. And I would like to know, now that you all are expert in craniopharyngiomas, what would you do? So let us know, what would you do? None of the speakers will be mad at you if you don't do what they suggested. Okay, interesting. 50% would do cyst fenestration radiation, 48. Cyst fenestration Omaya, transsphenoidal resection aiming for GTR. Okay, good, interesting. I'm a little bit surprised. So, let's ask our experts. Dr. Pica, can we, in such a tumor, if I present to you this kid, would you say it is safe to do proton therapy, or do you see any problems?
I see the problem because this patient is not symptomatic. He has no visual deficit. The pituitary axis intact. He has just this growth hormones retardation. He's not symptomatic. So I would not put the radiation as a treatment because there is no reason to do any radiation now.
Okay. What would you say is if he were, let's say he had visual deficits, is the volume here of the tumor for you a problem in radiation? Or is it okay to do radiation in...
The volume is not really a problem. The problem for me is that this cystic component that is going in the hypothalamic area, and we know that as well we are toxic for the pituitary area, we are also toxic for the hypothalamus. So the first question in a tumor board I would ask to the neurosurgeon, can we reduce the amount of this cystic component? I mean, just to mention maybe that the proton therapy are less sensitive to this mixed tumor, cystic, and so on. There are other treatments.
What would be ideal for cystic, if not proton?
If it's completely cystic, if you have the expertise, you can do if you have only a cystic, you can do brachytherapy, but you have to have the expertise because you see this overview where only 66 patients, and otherwise, if there are no other possibilities, protons can be also possible.
Okay, but you would like to have less volume before we do radiosurgery, before we do a proton.
If there is an indication to treat now for
yeah.
Reason. Yes.
You would ask the neurosurgeon, and that's what we're going to do. Please pass the microphone to Professor Constantini.
I don't need to even use, I think, that.
Yeah, it doesn't work.
Is it on?
Speak like that.
I don't need
It's for the feeling.
Yeah. You're doing it because you are online, but you hear each other. One.
Okay.
So this is a new case, right, Yuda? It's a new case, and it's the picture on the left-hand side.
This is all new presentation.
Right.
Not touched.
Right. I would say not to treat surgically would probably be wrong because this patient is on the verge of producing hydrocephalus that could be an acute hydrocephalus. And also, if we elect to go for radiotherapy, I would like to have a catheter in the cyst. So if the cyst grows during radiotherapy or in the year following radiotherapy, which happens, I would like to have an opportunity to drain the cyst. So I would do a cyst drainage procedure, as we discussed during Yuda's talk, either endoscopically or directly stereotactically with an Omaya.
Raphael's talk, yeah. Okay, so you would do it probably stereotactically into the cyst.
Yeah, there are advantages as we spoke because if you overcome the issue of penetrating the wall of the cyst, which can be an issue, then you can have the trajectory, the optimal trajectory for the catheter to sit. You can do the calculation of exactly how many holes you want to have inside the cyst and not to have holes outside the cyst that can drain CSF. And I think the drainage later is better because you don't have CSF coming into the catheter. But doing it endoscopically is a valid option, of course.
But you mentioned hydrocephalus, so with this we don't control potential hydrocephalus
because of blockage of the third ventricle. And it is true with, you would think that if you drain the cyst, the third ventricle would open. If it wouldn't, then you would be forced to do a septum pellucidotomy.
And maybe put a catheter that drains both.
Yes.
Okay. So if you have hydrocephalus, think about it that you want to drain maybe both. If you don't, you can do it maybe stereotactically. Still a matter of debate. I would like to ask Professor Mariani, let's say he's on the left. Let's say this is an adult, young adult, 18, 19. We're less worried, maybe a little bit less worried about the hypothalamus. Would that change the course of your, what will you do surgically?
I think I would have another treatment algorithm, yes. Probably my bias, I believe that an 11-year-old boy with growth retardation is a problem, clinical problem, and I don't want to endanger him from his pituitary function, because I believe that the substitution is more complicated than in an adult. So it's a little bit my bias, and I would prefer to definitely keep the pituitary function as long as possible. But then I would join the point that there is a potentially life-threatening situation. So I would reduce basically the same you say, but probably more like Raphael suggested. So endoscopically take the biopsy, maybe reduce if you can reduce, and then put a good catheter in a good placement, very well controlled on the visual control. And in an adult, I would have another attitude. I believe I would probably do the same technically, but I would do it with the purpose of reducing the lesion down to a Pica lesion.
This is a typical in the tumor board from Lausanne when there is a problem with the Pica, they look at it.
Okay, so you see, the philosophy in adults is a little bit different. Would you come from down, from below? Would you come transsphenoidal?
Well, I didn't comment on but I think it's really posterior hypothalamic. We can see, I think, the mammillary bodies. I think we can do a lot of harm, potentially from the perforator, even in an adult. So you mentioned this. It's not just only about obesity. It's about all other things that happen there.
There's another thing. If you drain a cyst from below, the cyst is drained, but it can be reaccumulated, right? Because you seal the floor in order not to have a CSF leak. So you drain it, you seal it. The cyst, you cannot do the drain when you work from below, right? It's contaminated per definition. So we have two patients that went back and forth 3 times to transsphenoidal because they were drained and they were reaccumulated. So I think if you have a cyst and you want to drain, it's better to do it from above.
What about open surgery?
I want just to say that, but I think there is a slim. So this is brain, right? This is hypothalamus that is pushed up, right? So we do not have a direct access to the. Well, that could be an option. I think if we just make a small window, you could maybe then reduce the capsule. But in the same philosophy so probably this would be the alternative of reducing the volume down to a better target for radiation.
Okay, great. Any questions from the audience? Just let me know. Okay. So, we did the endoscopic cyst fenestration. We put an Omaya. And now one thing we also discussed is what is the next thing we should do? Should we just follow the lesion? It looks much better, right? Should we go for a transsphenoidal resection because we see that?
How do you put the Omaya? When you're with the endoscope inside, how do you guide the Omaya?
He's not going to let you go with that.
Yeah.
Shlomi, I will invite you to our OR and I will show you.
You don't know. You don't know. You've got to teach you. You put it parallel to your endoscope.
Yes. We go with a stylet in the beginning.
Stylet parallel.
And it's a forehand surgery. You need 2 people who know endoscopy. And since we have that in Basel, I would say, but seriously, you need 2 people who are a little bit trained, and then you go with a stylet parallel to the endoscope. Usually, there's enough space within the burr hole, and with the endoscope, you guide it a little bit.
Through the peel away, right?
No, you have to take away the peel away because the peel away is too small. Or put a bigger one. We do it without the peel away because the tract is there then after the peel away, and do it, parallel to the endoscope. At some point, when you're near the goal which you want to go, you take out the salad and you just push in the catheter. Yeah.
Sorry.
But Jonathan does it.
Plumbing.
Plumbing, yeah. So, do we want to go for radiation, chemotherapy? I don't know, or other suggestions. So, again, let's see what you think, guys. Andrea, why aren't you participating? Oh my God.
Oh, no! Who is that? They were so impressive from the
You did a good job, you see. Okay, so I think it's quite clear. Most of you would follow. 80% would follow. 20% would send for radiation. I'm going to ask you as an oncologist, because you are a part of the tumor boards. I know it's not the expertise, but what is your feeling when you do the follow-ups in these craniopharyngioma patients often? Do you have a feeling this is something that we need to stabilize early, or do you think we can just follow?
So that's now the question in craniopharyngioma, which is not answered yet. Because if we would proceed for radiation or surgery, it's kind of a prophylactic treatment because we want to really prevent like visual loss or some other damage to endocrine deficits. And this, unfortunately, is not answered yet. That was like one of the trials Hermann Müller tried with like doing like early versus late radiation. It didn't work because there was just like not much. I mean, they were eligible patients, but no one really, as soon as they saw it, they were either just directly going for radiation, but no one was waiting and doing it later. And I think that's a really interesting question, analog to midline low-grade gliomas. It's exactly the same scenario, really. And I think what we have to keep in mind, it's a chronic disease. So whatever we are doing should do the least harm. Because these are children and then adolescents and young adults who maybe multiple rounds of treatment. And with each treatment, I think the risk of damage is going higher. There is a risk of not doing anything, but there is also a risk whether we do surgery or whether we do radiation, or I don't even think any of the newer treatments I showed to you, they will all have risks to that, and that's a balance.
So maybe before I come to you, Professor Constantini, Dr. Pica, what would you say would you say it's something that we should do? We should radiate?
Based on the data published until now, I would say that we have to follow the patient because we are not in a hurry to treat and to make a toxicity. Mm-hmm. Now, what we open the door of maybe that the future trial they have to based on not only clinical, radiological, morphological issue, but also omics. Somehow to stratify the risk of someone in the same, which patient in the same situation will develop in a very short time complication linked to the tumor, and then needs so we can take the risk of a treatment in order to reduce also the risk of. But now we don't have this data. So with the data we have. And with the analysis we can do, I would say that we follow the patient. Anyway, is a tumor like this is a follow every 3-4 months, etc. So there is a sign of progression, radiological or clinical, because also there are two different things. If there is a radiological progression, but the patient, and you can go again with drainage, we can also have a little bit larger follow-up in order to postpone the radiation. So for me, it's a discussion based on this.
You don't think it would significantly reduce the risk that it will grow if we do radiation?
Yes, but you have for a cystic tumor. For sure, so it's better always to have, volume reduced but we can take a reduced volume with a second cystic biopsy or cystic drainage, and then do radiation. And then we have also to check how is growing this tumor, because maybe it's stable 6 months, 1 year, and the patient is still without symptoms. Or we have tumor which are more aggressive, and the one kyst became polycystic. In this case, we have 2 different tumors coming.
Mm-hmm. Maybe you pass to Professor Constantini. I know he has a hard opinion about this.
Yeah, for me, all the surgeries which are partial surgeries, if it's STR or certainly if it's minimal surgery, are a package deal with radiotherapy. Unless the patient is very young and you think there's a difference, the patient is 1 year, 2 years, 3 years, 4 years, you want to bring him, another year or 2. For me, all these tumors grow, which is very different from low-grade gliomas. Low-grade gliomas are very erratic, and things happen irrationally. They may involute, they can be strange things. So if you have a small low-grade glioma, I think it may be reasonable to follow. But if we speak about this patient specifically, you drain the cyst, now is the best time for radiotherapy, because anything from now on will be growth, either the cyst or the solid tumor. So your target will be bigger, therefore radiotherapy will have to aim about a bigger target. If he's 11, I think he was 11,
He's
right?
11, yeah.
11 years old. And also, all this follow-up is a tremendous burden for the family. You want to finish the first stage of treatment. What you did is a temporizing measure. It's not treatment, really. It's a temporizing measure to relieve symptoms, if there are symptoms, and to prevent hydrocephalus, and to reduce the target. From now on, things will be worse. They will not be better. So I see no point in following this patient. I think the German study, it was Muller left, I think.
Yeah, he left.
Right.
He left, yeah.
The study trying to stratify collapsed. It collapsed because of a reason of a lot of people that decided that following this patient does not make any sense. So I'm in minority here.
But even if we do radiation, we still have a risk that it will grow.
Sure, there's a risk.
And
Yeah, I agree.
We have to follow the patient anyway, because as I mentioned, so depends if so we have 2 scenarios. So if you do just intracystic brachytherapy, so the dose is outside of the wall of the kyst is very low. But if we treat with external radiation or whatever, stereotactic radiosurgery, you have to follow the patient, because if we are treating a pediatric patient, so the toxicity.
Mm-hmm.
And if you have a big tumor, so unfortunately we have also the vascular risk. So anyway, these children are into the MRI every 6 months because of the risk of toxicity.
Everybody is followed forever, of
Yeah.
course. Yeah.
That's Mariani.
I'm not sure that we are completely off. That's what I say. Basically, in an adult, I would say we reduce the volume and we go for treatment, because I also believe that a tumor like this will be progressive at some point. And I think in an adult, it's just what you take into as a risk is that if you can save the optic pathways, and well, of course, we have to have a closer look into that. But if you go with the optic pathways, there are almost no risks there, and the only risks are endocrinological. I believe we have to accept the risk of standard mortality ratio of, but they are going to develop unlimited some years after the treatment. Probably here at this point, I have the question to the radiation therapy. The best radiation that you can make in an 11-year-old, when would you anticipate the hormonal breakdown, so the liver insufficiency?
So anyway, we are responsible because if the tumor is in this area, we irradiate it in the pituitary. So we are also responsible.
Right. And when do you expect the pituitary to?
The process is very slow, but it starts at the end of the treatment. So the first is the growth hormone in the first year, and then you have the other following. So And we know that we expect this kind of toxicity up to 15 years from the radiation. So,
In how many percent of the patients? Is it like 100%? Yes. So that's also something to keep in mind.
There are quite nice data from Manchester, from Christie Hospital with Steve Jarrett. They looked really the old irradiated patient. And it's true, the growth hormone axis is first, the flip and ventricle navel, and at the end the thyrotrope and the corticotrope in between as well. So, and that it can last 10 years until the first comes, and it can last only 3 years. It's really, you need to check for that.
May I ask a question? I'm not aware, but are there data comparing the growth of these tumors with or without radiotherapy outside of the study that was planned and not finished? But from historical data where you would say, okay, if we don't do, we expect a growth which will cause significant problems in 1 year, in 3 years, or in 12 years. So this is provocative, of course, to restart. Should we do it immediately or not? But does anybody know about such data which could help us?
There is no such data. The doubling time of craniopharyngiomas cannot be projected at the time we see the patients first. It can.
Mostly because of the cystic parts that are completely erratic anyway.
Most of the solids may grow.
And they may not, and maybe stay longer.
No, but it will grow. I've never seen such a patient without radiotherapy.
But I believe that the issue that we are having here is just how much time should we put between the two treatments in order to keep safe. And so I think this is just an open question. We don't have the answer. But I think that nobody would argue that this is not a package. Surgery plus radiation therapy is what we have that works.
We changed. We went from radical surgery.
Right.
So and we're doing something minimal. We just drained the cyst. There's a tumor there. The cyst grew. The tumor is active. We don't know if it will grow in 3 months or in 2 years, but it will not grow in 5 years. It will grow, and we have a definite or almost definite treatment. I would say 80% right control rate in 10 years or something like that. So, yeah.
Yeah, sure.
Is the occurrence of radiation-induced moya angiopathy dependent on the age at what time you will give? So let's say delaying it maybe might reduce the vascular injury, for instance.
Yes,
That's interesting. I don't know.
Yes, as I mentioned, the last paper on the vascular, it was the age and the presence of re-treatment damage. As I told you before, I have the impression, more than impression, that all these trials are only based on clinic, but we don't have omics. So nobody is going to looking for the vascular risk factors from imaging. Nobody is going to check. There is a paper with resting state fMRI. If this patient already at the beginning of the disease they are damaged in the neuronal connection, etc., from the neurocognitive impairment. We know only that there is a tool. We know that the classification, surgical classification. We know that all this clinic, but we cannot really stratify the risk also based on other more robust data coming from imaging, so radiomics, or coming from other point like molecular, as we do normally in pediatric oncology. Now all the tumors are stratified based on genetics and molecular class.
And maybe Shelley can comment. I mean, do we need to do a special MRI? Just thinking about it, or do we need to do an MRA once in a while? Or
no, because I'm actually thinking now, maybe what you're saying, maybe at presentation, we never do for craniofaryngioma. I'm listening to what you're saying, and I'm thinking that maybe straight ahead at presentation, we need to do like a full vascular study, which we don't normally do actually for craniopharyngioma. This was never the question at the presentation time.
Remember Mary, our patient Mary, and when we look back, he developed moya after surgery. But when we look back at presentation already, he had some narrowing of the A1.
Because his tumor was all out there, enveloping, but as a radiologist, I would say yes, that it is within the circle of Willis. It is encasing, and I would suggest which are better, but I'm thinking more to like warn the surgeon to not go into those vessels or something. But what we are saying is actually let's do a full, for this child, like our full moya protocol, although he doesn't have yet moya, just to assess the actual extent of narrowing of several vessels and to see if there is already any kind of collateralization there.
Moya, we follow like this.
And also on our follow-ups, which we don't do routinely for these patients unless we suspect that it's becoming a moya status. And then also perfusion, and then also some. So yes, that's very interesting, and we need to maybe.
On standard MRI?
The what? The IV sign? Yes.
Tissue suffering.
Yeah.
You see on the standard.
Yes. Because our standard protocol will be with, as I said, T2 dark fluid, although it's usually not that helpful in the case of pathologies of the cellular region. We still use it, and we will see an IV sign. We don't usually, at least from my memory, I don't think we usually see that. But it's also maybe good to even look at the data we do have and just go retrospectively to the primary studies and look at that again.
And then we have aneurysms, in patients who were operated upon. A different question, right? Whether they need to be quite early. They're usually tiny. The calcifications that were peeled off the circle of Willis. We have a couple of patients like this. I don't remember we operated on any of them. I don't remember any subacute hemorrhage that tiny.
Interesting. I see academic discussions cooking in your mind and publications coming to us, but that's good. So we're going to leave this topic because we could, I think, debate another 2 hours. And we talked about it, and I think it's a very, very important question. Should we give growth hormone? And I see some of you already put in an answer. And even though we discussed it, maybe we go shortly over it again, because it's not only a topic in craniopharyngiomas, by the way. In pediatric neurosurgery, as you know, we have a lot of incidentalomas. And many patients where we find incidentalomas have MRI, or pediatric patients have MRIs because of growth retardation. And then you find something, a lesion, which is not in the pituitary, you find a lesion in the cerebellum. And then the whole discussion starts. With oncology, with neurosurgery, with endocrinology. And it's very important because these patients, as you showed, are suffering. So let's just debate on that again. So in this specific patient, Professor Szinnai, I knew you would have an opinion. Would you start growth hormone therapy? I don't have the curves, but let's say it's insignificant, the growth retardation. Would you start early? Would you... We are not radiating, so we can't really talk about stable disease, let's say. But would you start, and when?
These are exactly the situations which are difficult.
I know.
And that's interesting to discuss. This is an 11-year-old boy. So his puberty will start, let's say, in about 2 years, maybe even later. We need the bone age to check for his biological age. And then we can see how much time is left for start of puberty and for a pubertal development of, let's say, in a mean of 2.5 years when he would stop growing. So this is not the 14-year-olds where we need to start as early as possible. Here we would have a little bit of time. And in this situation, when we don't do anything, I would a little bit observe, because eventually, if we really, the tumor in the first 12 months is growing, we would decide to irradiate, or we irradiate immediately, then we are much safer.
And let's say it's a 14-year-old, you say we have to start now, and we do the follow-up and it grows. Do you stop treatment?
That's a good point. There is, let's say, a situation, I would try to get stability into the story. I wouldn't treat during this growth. What we had recently, you remember this discussion we did a long time. We then didn't start, we irradiated, and then afterwards we waited a little bit, and then we started really with a good dose without any fear. And then any ambivalence is out of the game. And I think this is probably for the parents also, and for us also, the best decision. Because it's a little bit like you said, Professor Constantini, sometimes we need to close a chapter, and then we go to the next one. Whether this is true in 10 years, we will see, but I think for the moment I would go this way because it's closer to what we did and where we have more experience.
Okay. Raphael, do you want to say something?
For the child, it was terrible. Yes, as you know.
Exactly, it was terrible for the child and for the parents also.
Every 3 months and say, can we finally start growth hormone? Because he was short.
Yes.
I mean, Apollo was short.
Some people are short, but that boy was suffering.
Yes, that's that we.
How accurate is your height projection? When you see an individual child, how accurate are you in giving his height when he's 20 without treatment?
Yes, without treatment we can't project. No, because that's the difficulty. We just can make the projection. You know, on these atlases with these pictures, which were done in the 50s, on two individuals, a boy and a girl, or let's say this is girlish and pale, and then down the White House has other two individuals, and on that, with a large standard deviation, the younger it is, the more imprecise it is. The more you get to the end, let's say from 12 years old, you get an okay prediction with a standard deviation from, let's say, plus minus 4 centimeters, but under the condition that he grows normally, and we cannot project anything precisely. It's a gut feeling, it's an experience, but it's not that you can say, okay, if we don't treat, we will be there. It's just a feeling, imprecise projection.
Professor.
Perhaps you are not aware, but growth hormone treatment in adults is also a topic, a very important topic. There, I just mentioned this briefly, growth hormone deficiency is very common. It's all nearly 100%. And growth hormone is a metabolic hormone, so it increases lean body mass, decreases fat mass. It does not lead to reduction of weight, which would be very nice in these patients. But in cranopharyngioma, with regard to quality of life, it has been shown that really improves quality of life. So in cranopharyngioma, young patients, I always suggest treating growth hormone.
So the patients who become 18, 20 and move to your clinic from your clinic, you continue growth hormone therapy?
I continue at least until to 25 years. Why? Because there are clear data that the peak bone mass is not reached after growth has stopped, after puberty, but it's reached at 25 years. So this is the bank account of your bone for the remaining life.
Yeah.
And that's why it's very handy to have a bank account for the rest of your life.
Yeah.
So I try to keep on until age of 25 years. This is not always simple because they have to inject growth hormone every day. So some of them got fed up and they can't absolutely see the utility, but most of them they carry on. And then if they are fed up, I perhaps stop it for 6 months, and then when they feel a difference, then we can start.
Then you can give them again. Yeah.
Maybe I can add an information on that. Also, Hermann Müller showed a very nice study that children who were treated versus children who were not treated, the quality of life is significantly better, growth is better, body composition plus quality of life long term over 12 years is better. So that's why also I'm very pro growth hormone. it should be in a situation where we are, let's say, where we got the feeling we closed the first chapter and we can go on with the second part of the story.
Katrin.
Maybe Gabor, that's a little bit like provocative. We are debating all the time, when is it safe to start growth hormone? And that keeps on, but we have no clear evidence that it really does something. I mean, we have like international groups, we do all these guidelines and stuff like this, and the result always is like we can safely start growth hormone, but still we're debating what is like a stable situation and when we should start, and this for decades now, from like some evidence which is also decades ago and never was proven again. And I think that's interesting in a way, because we're doing the same effort now with the International Guideline Harmonization Group, really to check all the literature again and stuff like this. And there is not a lot of evidence for the whole discussion we have all the time, me included. I mean, we are all doing this, and for sure we always want to be safe. And then it's like, yeah, what means stable? 3 months, 6 months, even more. And I think that's really interesting, because we always say we're so evidence-based, and sometimes we're not so much, I have to admit.
But Katrin, you as an oncologist, maybe I can just, are you worried if you have a tumor and we give growth hormone? Is it something that worries you?
No, not, but that's what's always in the back of the mind, and that I really think we have tried to close this chapter at some point and really see if we ever found any evidence for this, and that's now the effort of the International Guideline Harmonization.
It's also a medical legal issue.
Yeah, in some countries,
So
yeah.
you need to explain to parents, but if you have a guideline, statement, you feel more safe as a doctor, to do something.
Absolutely. Please read these guidelines, because they're very interesting, and they really go also into this point. One of the first points, there are 15 summary points, is there a difference of what we observe from growth hormone, the IGF-1 in vitro growth to in vivo growth? And there seemed to be, luckily, a difference. So that's why these guidelines are more progressive and more courageous than what we had before. And there is, you said, we have no evidence that it's good, but the evidence is there is no evidence accumulating that with growth hormone we make some harm. So this is the other way around. This is what we can do, but it's the best of the knowledge we have currently, and that's why I think it's really an important thing to, for each child, take an individual decision, but with this knowledge of we don't need to wait each time 2 or 3 years.
Okay. So the next chapter, and that's also a very important question, not only in craniopharyngioma, but in pediatric neurosurgery. These patients are 3 years old, 4 years old, and now they have to be followed. And we heard about gadolinium, which can cause problems later in life. We heard about the stress of the families. How should we follow this patient? So here I would like to have the opinion of you, first of all. Just given a scheme, try to type in something. What do you think? 3 months, 4 months, maybe also long term. What do you think would be the right way to go? In terms of not how long in life, but what are the gaps between follow-ups, if you can? Six months. I always like the term 3 to 6 months. These are my favorites in the tumor board discussions. Should we do it at 3 months and 1 day, or at 6 months minus 1 day? But it's interesting. Okay, so I was hoping for this. So you see a variety of opinions, okay, and that's exactly the problem that we have. We probably don't know, but still we can discuss about it. So how often do you think we should follow these patients? Since I know your opinion, I'm asking you.
Every day.
Exactly.
That's what oncologists
A WhatsApp every day.
Once a day, just to make sure.
They should write you a WhatsApp once a day.
We get one MRI after the surgery, right? That would be a rough, full of artifacts baseline.
So that will be like 24 hours after surgery.
Yeah.
Okay.
And then we would do one in 3 months after to have a more solid baseline, and then would spread out to 6 months. But my guess is as good as anybody's.
Okay. And 6 months, and then you would go annually probably if it's stable. Or how long do you continue 6
If
months?
this is an untreated tumor, I would stay at 6 months. If this is treated, I would probably do 6 months, and then spread to yearly.
Yearly. And then for life.
Yeah, forever.
Forever
Like
and
every
ever.
person.
Okay. So,
I
Professor.
think it's important not only radiology, it's also the clinical exam, it's ophthalmology. I think we have, and endocrinology. I mean, this is really a team effort. And I think that's also something we have to explain the parents. The MRI tells us a lot, but not the whole thing of the story. And an MRI can be unchanged, but symptoms can progress, and then we still have an indication.
The question will follow. I'm going to ask Professor Gutzmann instead of Mariani.
But I can tell you what he would say, maybe.
I know what he says and I know what Mariani says, but let's hear what you have to say. How would you follow these patients?
Yeah, I would also get a scan after surgery. I don't think it's critical to get it after 24, 48 hours. It's not a malignant tumor, but baseline, let's say within 4 weeks. Then 6 months. Then I think if we don't see a dynamic, maybe another 6 months, and then yearly. I think at some point, if we have what we think a stable situation, we could go to a yearly, but 6 months clinical exams. Like intertwined the clinical exam and the MRI.
Yeah. And if now you followed for 10 years, would you yearly? Would you like do 2 yearly, 3 yearly, or would you continue for life yearly?
I would go to 2 yearly and I would spread.
Professor Constantini, you will stay at yearly.
No, not
You will also
necessarily.
spread.
I mean, if you're 3-4 years and it's stable, I think you should spread more.
Oliver, what is your opinion?
No, I just wanted to ask, wouldn't it be smart if you talk about, I mean, I hear about 16 MRIs in the next 10 years. Wouldn't it be smart to pick up your idea of maybe not using gadolinium every second time?
I would actually ask that we have to use gadolinium in all the follow-ups at all. But for this, maybe we need to do also an evidence-based study just to show, did it change anything? Because we see that the tumor grows and you see that the cyst grows on the regular anatomic MR imaging. We don't need the contrast to see that kind of growth. Even for the vessels, we can do time-of-flight MRA without contrast. So the real question is, does the addition of the contrast add to your treatment decision? And if the answer is no, so we use the contrast at first to identify and define well the tumor. We know it's a craniopharyngioma. If it's growing, we see it without the contrast. So it's a question. Do we need to continue at all to give the contrast?
Totally agree.
Maybe not at all, not even every second year, but just if we see change on native, then we will give contrast, but then you need a radiologist who looks at the images while the baby or the kid is sleeping, especially.
These are older kids already, and maybe
So
we're
maybe
out of that
yeah.
sedation phase. And if we're out of the sedation phase, then even in places if you don't have a radiologist on call, you're not, it's not too bad. So the child came, had a study without contrast. Radiologist read it and said, you know what, there is a change. I want also contrast.
You could
Bring
repeat
him
it.
back.
Yeah.
I think more important than the gadolinium issue is to do the MRI at the same place and have the same team examining it. I mean, even in Israel in our clinic, I mean, Shelley is here and Shelley does it, but sometimes the insurer wants the kid to do an MRI in Nazareth. Why? Nazareth offers 10 shekels less money for the MRI. So the kid drives for 2 hours to Nazareth and comes with a lousy MRI back. And it's not even in our system. So it's so nice to have everything centralized in one place. But this is ideal. It doesn't always work.
Yeah.
Maybe in your comment at the last brain tumor group, imaging group was
clear proposal to not to do MRI for cranio with the gadolinium. So it was a clear statement. By the way, I would say that if for vascular we can avoid this, and if there is a sign, then you can complete the examination. But in principle, the guidelines will go in this direction.
Oliver, would you agree with what was said on follow-up? Would you do the same?
Yes, but I'm looking forward to go back home and talk to my neuroradiologist and suggest not to use contrast anymore.
Yeah.
They will look at me and say, why? But
So
yes.
give them Shelley's phone number.
But Katrin is coming to us.
Or
so
Katrin,
I
yeah.
will have a friend.
But Shelley can explain it to them also.
And for the record, I think that the gadolinium phobia is exaggerated.
True.
So that's my
Absolutely.
Okay, it maybe, yeah. But you know,
I have so many patients who did over 50 MRIs in their life, and I haven't seen really. I know it's been reported, but you know, we had the phobia from anesthesia. Remember, there was a phase that they said repeated anesthesia and MRI causes trouble. I think it's a bit exaggerated. I don't say no, but
Shlomi, there's also a needle phobia of the kids. You know, if you can spare one more needle for the kids, they will be happy. If you go to the MRI and sleep and go back home,
and
it's not a bad
the
thing.
MRI and cost of the MRI.
Yeah.
If I can just add something to that. I agree with you that we don't know yet. It doesn't mean that we won't find out in the future what is it causing. But I would say that I think we moved in pediatric radiology to the state where, 10 years ago, we were all about radiation and CT, right? Because we were scanning 3-month-old babies with the same radiation like an 80-year-old adult. Now we adopted changes in practice, vendors came along, CT now gives a really small amount of radiation per patient, so now we're okay. But everybody is already panicked and moving away from CT too much, so now I'm finding myself bringing them back to CT when it is needed. So I think, like everything in medicine in general, it's a risk-benefit situation, and in everything you need to decide. So yes, I will not avoid giving gadolinium, but why give it if it doesn't help us? Like if it doesn't add any information, why give it? I think that's the main question. And I think that's where we need to go, not to be like this reflex or automatic things, just individualized medicine, right? We like to hear that today.
So,
I mean, this microphone is not functioning, I'm just telling you.
You sure? Just need to know how to use it. So I went into the literature a little bit, and I found this interesting paper. Of course, it's not evidence-based, but just to give you an idea, they went for a strategy based on how the tumor was treated, and they also do close follow-up, and then they do the gaps a little bit wider, but that's the essence of the discussion we have here. But me personally, I do think that clinical evaluation is very important. And Professor Christ is not here, but Professor Szinnai is still here. And I think we need to focus more on the clinic of the patient and less on the MRI. It's also important, but I think usually when patients have progression, they show some symptoms. And let's say in this patient, how would you follow him chronologically?
So patients who have deficits and who need treatments, we see them every 3 months because we need to adapt, especially in the first time, even more often until we titrated the minerine dose perfectly. Hydrocortisone is quite straightforward. Thyroid hormone is simple. Growth hormone is not that difficult. There we need security. But this is a standard we have here because, well, maybe also the distances are not that long in Switzerland, but this gives us a good security. After years of stable dosage, I know, for example, my friends in Montreal, they see them less frequently because the distance is much longer. But you need to decide always individually which patient is let's say, has a good compliance with the medication. This is also important, and need to be re-instructed or makes problems because they don't follow the dosages. Which patient is well growing on the growth hormone dose, and where you need to titrate higher, and then you need to have more frequent IGF-1 controls. These are all things you need to consider for a perfect treatment outcome. But 3 months is that what we use normally.
Mm-hmm. And once they're stable, you also go for annually, or do you need more?
No, because the children grow and they gain weight, and you don't want to miss the time point when you should increase the dosage for all the hormones. And for growth, you don't just need growth hormone. You need thyroid hormones and then at the end also testosterone or estrogen. So this is a concert of 3 hormones which guides you through a pubertal growth spurt. And if the pubertal growth spurt is not perfectly timed and dosaged by us, you lose a lot of centimeters in this very short time. So these are periods when you really should be close to the patient and optimize your treatment. And this is not just standardized every 6 months, but you want to have optimal guidance of what you do, and it's the context of all hormones together which makes that you provide a good therapy, you provide a okay but not well-controlled therapy.
So, Captain, let me ask you, what kind of clinical follow-up do you think these patients need? So, endocrinology, is there anything else you would suggest doing?
I mean, they need ophthalmology as well. I think they need like the whole oncology team. I mean, we heard about the social stuff.
This microphone.
We heard about social, we heard about school issues and stuff like this. So they really need our whole team. And hopefully, I mean, what I would wish in the future, if we don't have like medication for this, like obesity or so, maybe some other intervention as we can do, like not to like completely take like this long-term effects away, but hopefully can minimize them a little bit.
But do we have already programs for these type of problems, like social worker, psychologist,
yes, they are. Like, I mean,
we have.
That's in the long-term follow-up clinics where they will go to at some point. Yes, they should be multidisciplinary in that way. And at least in Switzerland, we have a general consensus on this. How this is done on an institutional level, we'll see. But like most of them who take this seriously have such a team.
And probably it would make sense to do the follow-up maybe in one place. If it's such a rare disease, you would spare all these personnel.
That would be
great,
out. But I think we're far away.
This is a political comment. Yeah, I know. Okay, so let's move on with our case. After 1.5 years follow-up, we have a growth of the solid part.
Surprise.
I brought this only for you.
It grew. Come on.
But hormones are stable, vision is intact. It just grew.
Yes.
Should we treat?
It is 8 times bigger.
Yeah, but should we treat?
No, wait,
let me know.
It doubles again. No, I'm kidding.
Slow it. He's going to get mad at me. Don't be influenced by Professor Constantini.
I'm here to be provoked.
Speak your mind. You're biased, guys. Okay, so still we have some people who say nothing. Endoscopic transventricular. Okay, most of you would go for radiotherapy. Dr. Pica, radiotherapy.
We started with a child of 11 years old, now he is 13.
Now he's 12 and a half.
Voilà.
Yeah, almost 13,
okay.
Yeah.
We can say from a radiological point of view that this tumor is now more solid than cystic, or it's more heterogeneous. And Which kind of radiotherapy? Depends where you are. So as much as possible conformal, and so we can do a stereotactic treatment and not a radiosurgery, I think, because we are too close to the critical organs. I would do a fractionated conformal radiation therapy, stereotactic treatment. We can do proton therapy if the facility is available where you are working.
Does proton have a benefit?
There is I think that for in
I'm
this
asking
case,
because Shlomi sends very far away for proton.
yes.
Do you need to send far away for proton? Is this something that you would recommend?
I think that far away, if I would not push so far the indication of protons, but we can discuss this, because with protons we can reduce the radiation of the more better than because now the volume is not small. So if you show me a relapse intracellular like this, I tell you, go ahead with a good stereotactic treatment. And now the photons, they do also nice things. In this case, so I have only a sagittal, I have to check, but if you put the GTV, so we have a gross tumor volume, you put between 3-5 millimeter of volume, and then you put the PTV, I think that the volume is not small. So in principle, if there is the facility possible to do protons, otherwise again fractionated stereotactic treatment.
Okay.
And
the risks.
The risk, hypopituitarism, the optic pathway, we will try to spare, but the risk is never zero. For that reason, I think that in children it's very difficult to do a neuropharmacological evaluation. But when they start to have 11, I think that more than visual acuity and just the visual field, I would also suggest, and sometimes we ask when there is a risk, the neuro-ophthalmological with the OCT evaluation.
Okay. Rafael, you're the transpheroidal guy now.
No, I would do radiation.
You would do radiation. Okay. But do you think there's place for transpheroidal surgery here?
In general, or in this particular case? No, in this particular case, I think even also it's not really intracellular, it's kind of high up. The pituitary gland is going to be in your way. So I think even though we have risks for the endocrinopathy with both methods, I think the radiation probably has a lesser risk, at least immediately. I think with surgery, you have a high risk to have an immediate panhypopit, with the radiation probably delayed, which can be a benefit for the child.
Hypothalamus in transpheroidal here?
I think just from the hypothalamus, if we had a coronal, but I know the case, I think we could probably, do a hypothalamic sparing transpheroidal surgery. Yeah.
Okay, but we would have a remnant.
We would have a remnant.
So you would have to discuss if you do radiation then again.
Yes.
Okay.
If we believe that a smaller volume is beneficial,
then we could reduce, but you wouldn't go for transpheroidal for the reduction here.
I would go for radiation.
Okay, but she says you need reduction. No, let's say. Hypothetical.
If she said, then I would.
Then you would do it transpheroidal.
Yes.
Okay, good.
You learned something in Tel Aviv.
Yeah. Now it's your turn, Professor Constantini. She says you have to reduce it. You have to reduce volume. Would you go endoscopic? Would you go transcranial?
In such sizes, I'm not into reduction. Of course, if the ventricles were huge, you may reconsider. If it would be very down low, you may reconsider. This one, no. The other ones, probably no, also.
And let's say it's bigger and you need to reduct it. How would you?
So that was exactly the case that Shelley showed, and then I showed that
with the interhemispheric.
That we went interhemispheric. That was the rationale to make the target, but that was 4 times bigger than that. Solid. That was the rationale on which I'm not really convinced, but that was the rationale. This side, no.
Is there a volume maximum that you say here I won't do radiation?
It's just abutting and pushing the hypothalamic. If there is abutting and compressing the optic pathway, because we know that there is risk factors with the supracellular extension for optic neuropathy and also vascular toxicity.
So it's more the anatomical things and not the volume itself.
No, it's because it's an indication of a risk factor from the critical organs around.
Yeah, okay. It's an important point.
I just want to mention something. I mean, something I never understood. I know I'm broadening the frontier. It is so acceptable to irradiate craniopharyngioma, but if you need to convince your pediatric oncologist to irradiate an OPG, you're probably going to die first. Our oncologist will take them to first line, second line, third line, fifth line, day one.
OPG for
everything before they would agree to irradiate an OPG.
OPG NF or non-NF?
Non-NF, for the sake of the argument. Yeah. Non-NF. So I think we've seen it is relatively safe. The vasculopathy, we still need to sort this issue. The moya. I still need to understand. I've seen the numbers, 13%. I haven't seen how many of those 13% really need surgery over time for the moya. How many of them have strokes? How many of them bleed? What is the clinical significance? Or is it just an imaging type of moya? I would assume that only a small number of those 13% really reach the clinical threshold to have symptoms, but that's a guess.
Yeah.
Yes. Well, yeah, of course, I could not tell you numbers, but we treated quite many radiation-induced moya young adults, because they usually came like 15, 20 years after having had the treatment at Loma Linda. Now speaking for Stanford, and they came with strokes. And you know, the moya syndromes like TIA, not so much bleedings, but TIA and strokes. And so we did quite a bit of bypass surgery in post-radiation moya. Not saying how much percent.
Direct or indirect? No, I'm kidding.
Direct.
Professor, just to add something that this problem of vasculopathy is known, and there is a paper published from France with thousands of patients with a longer follow-up of 20 years treated in the brain for whatever brain tumor, and we know that the risk is very important, and the threshold dose is 10 gray. So here we are talking a level dose of 54 gray, 50 gray. So anyway, for the positioning of the tumor and the dose we deliver, we are completely in 100% in the risk.
No, that was not for you. That was for
Professor Scheinemann, anything oncological? I know we heard your talk. It's a little bit devastating, but do you think, maybe we talk about the future, you think anything oncological will be possible?
Potentially. I mean, right now, I would say, like, not outside of one of these trials I've demonstrated, and then that's a question, because then you have to leave the country. But I would not do this outside of the clinical trial at the moment.
So no oncological options at all. Okay, good. Just wanted to point that out. Professor Szinnai. So we heard about hypothalamic obesity and sleep disorders. I wanted to ask you, in pediatric patients, do you have a concept? Do you have a way that you treat these patients? You know, not only medication, but also psychologically, socially, because I guess these patients' lives are really ruined, and these are kids. What is the concept we have here, or concepts you've seen abroad?
So the risk of hypothalamic injury is, of course, much lower than 15 years ago, and that's a very good development. So the patients we follow now here, together within the neuro-oncology board, but also in endocrinology, where we see regularly every 3 months, luckily we have no obesity patients for the moment. Of course, we look at all these metabolic parameters, and sleep disorders, luckily, also are not very dominant in these because this is linked one to the other. This doesn't mean that we won't have, and as soon we will have this critical weight gain, of course, we include them into. We send them to the dietitians. As Emmanuel said, this is extremely important to talk early about these things. And then there is already a certain awareness of the family, and they will look for that much better than if we just let them run into the problem and then we run behind the problem. This is the thing. Psychological support we have. Always organized if necessary, and these patients, they are often under stress, they have problems, and we do that mostly with our psychologists we have here, and they get the support if they need it, short term, long term, but luckily we get quite rapidly possibility for the patients, 2 weeks maximum waiting time. So I think this is, outside of all we discussed here, a very important surrounding that will help to improve their situation and their quality of life. It's not just what we discussed here, it's the whole holistic approach to a patient, and these other disciplines are extremely important to prove also the parents, the families, the kids also, that they are looked at from all sides, and all problems are integrated into the treatment.
Yes. So I think this is a very important point for everyone who's here. When you see patients like this, you can't think only we neurosurgeons think surgery. This is a multidisciplinary concept. They have to meet the endocrinologist early. They have to meet the oncologists early. Radio-oncology is difficult to meet early, but they have to meet the neurologist early. It's very important to involve everybody early, because I can't tell them what Professor Szinnai can tell them about endocrinopathy. I can tell them what Professor Scheinemann can tell them about follow-up, etc. And I think it's very important to have this concept if you treat patients like this. I would have another question for you. Transition in pediatric patients is also a very, very emerging topic. We see more and more publications. We see more and more concepts. We actually published something on transition in brain tumors, which includes also craniophryngiomas. So endocrinology, I will ask you, endocrinology, how is your work? He's not here now, but how is the work? Do you pass these patients over to the endocrinologist and he follows them up? How is this settled here?
Yes, we have a long-standing transition program with the adult endocrinology department, also not just because of craniophyrangiomas. We have care here for about 200 type 1 diabetes patients, so that we have every month several patients who go over to the adults, and this is well organized. And the specific patients I always choose for craniophyrangiomas, of course, Emmanuel, because he is the hypo-pit guy of Switzerland, so he knows best what to do with them. Often we discuss already before, and he comes over one time to see them. I come over 1 or 2 times at the end, but with him also, he will care for the kids, I know, because the young adults, he won't let them get lost in transition.
Yeah.
This is very good. It depends. The patient can choose with us. It's between 16, 18, and sometimes they say, well, I don't want to change now. In half a year I finish school, and then there's anyway a change in university, and then I rather change directly to the next team in another town. So we are quite flexible, and we ask them, starting at, let's say, close to 16, do you think it's okay here within Children's Hospital, or do you would like to go over? It's a process where you not just send over, but we go with you for 1 or 2 times. This is discussed individually, but it's a very good process, and immediately we exchange quite rapidly. That's very well.
So the point is, you need to know who is going to follow them afterwards.
That's
when they're
very
adults.
important. Of course, you need to be sure that they are with somebody who will stay. If you just send them over, there is one young fellow who will change in 3 months to another department even, then of course transition is not ideal. So this was also something we learned over these years since the hospital is here, because we are much closer, and then we started to say, listen, these patients come back to us because somehow they don't find the contact to you or your department or the doctor of your team, and they come back to us because we care for them for 15 years.
Yeah.
And then we restart the transition, and out of this we learned that you need to have a dedicated doctor there who really will be there at least for 1 or 2 years, so that the transition phase is stable. And then of course there are changes to other hospitals, but then he can give it over to a fixed person, and not just to bring them over the street and then that's it.
Shlomi, how do you overcome that?
It's nice, but it's utopic. I'm not sure that I have in my hospital. But first of all, many patients are out of sick. They come from far away. So they're sort of forced to go to other facilities. Then the insurer would not always allow them or give coverage to come back to our hospital, or the hospital where they are offered. And third, within our adult endocrinology department, there are probably 20 or 30 physicians, and I don't think they would like very much to be individualized like we do out of choice. We like that. So I agree with you very much. It's an ideal thing that you give your patient to somebody you trust, and will be very accommodating to your patient, but it's a high standard.
But do you follow your patients, Crinopharyngiomas?
I don't.
Oh, no.
Maybe one remark, it's not just that we transfer them to the university hospital. There are some other endocrinologists who we know we have experience, sometimes far away, but mainly we try really to keep it in the same place.
That's a good standard.
Yeah. So you have to think about transitioning these patients, in every pediatric patient with chronic disease.
When you speak about oncology, for example, let's say you decide that you're going to follow until 25, let's say. It's okay in the clinic, but once the patient needs hospitalization because of some reason, the ICU would not take them because they're more rigid with their criteria of accepting to be in-house, and then you're in trouble because you mix between the big hospital and the small and the children's hospital. But that's I think it's a big advantage of having the pediatric hospital, the big hospital, under the same campus, separate from what is customary in the US to have a standalone pediatric hospital when they move to another campus totally, so they feel lost in the other world.
Okay, for the sake of times, we could discuss another 2 hours, I guess, but I'll ask you guys, would you follow these patients for life? Shlomi biased everything here. You see, there's still some no's.
I learned it from Roger Beck, he told me.
But he's 71 now, so at some point.
Katrin, would you follow for life?
Yes.
Okay.
Only if we would gain evidence in the future
that we don't need to. Okay, so I would like to thank you very much